I'm really very glad to be here and grateful for the invitation to be present. I understand that I am at something of a disadvantage, not being a health researcher or an academic of any sort. Civil servants of my generation tended to learn on the job. That is fortunately changing. We do have civil servants like Desiraju who bring academic rigor to what they do in their work as civil servants, but it was not necessarily so with people of my age. But I would just like to draw on what I've learned in my many years in the health sector, both in the States and in Delhi, and place a few issues before you. None of this is original. All of you are familiar with these facts and with these points, but I just thought that placing them in some kind of order would help in focusing the discussion. Now, there are many, many barriers to access, and we've had a very fine presentation from Professor Doyle on gender-related barriers, and I will say a few words on that, but not too much. But we can try and categorize them in many ways. And one simple way, the place to start is the whole question of physical or infrastructural barriers. Do we have the facilities? A recent report I saw said somewhere that there are 19,817 government hospitals in the country. Now, this includes everything from something like the AIMS to a sub-center. Everything classified under the category of a government hospital with something like 6.3 lakh beds. Now, looked at in any way, this is a macro figure which doesn't go into details of distribution, location, are they in urban areas, rural areas, tribal areas. But looked at in any way, this is a very, very small number. So, given the size of India's population, clearly there is one big issue related to just availability of health facilities. Now, this is also important because it makes the question, given this limited number of facilities, who is using these facilities? And the same data I looked at, which said that only 22% of the rural population and 19% of the urban population access government facilities for outpatient care. Now, this would again vary between states, but basically 20% of the population, urban and rural, is accessing government facilities. This does not necessarily mean that they're accessing no facilities at all. What it probably means is that much larger numbers of people are going to private paying facilities, which again in itself creates its own barrier, that if access to healthcare depends on my ability to pay for it. But clearly I will not access the best care possible. I will probably take shortcuts. These are issues we will come to. But the short point is that with government being a huge player in the provision of health facilities in the country, it still actually has provided only a relative, the government infrastructure is limited. Access to outpatient care, inpatient figures are not substantially better. It's still very limited. Now, so huge parts of the country where there are no private facilities, and or very primitive private facilities, and the government public health center or the primary health center or the community health center are the only available facilities, and there are other problems associated with them. Then the physical access itself is a very big problem. Now, what has government done in trying to respond to this? It responds again at a very simple level through NRHM, for instance, with huge investment into simply construction of new facilities, which in itself not a bad thing, but by no means sufficient. By encouraging and enabling state governments to put money into the construction of new facilities, and state-wise data is available as to who has done what. Several states have shown an ability to invest their own resources into the strengthening of health facilities everywhere. So as I said, this is not in itself a bad thing, but taken on its own, just the construction of a building is certainly not enough to be able to establish any minimum level of health care. There are other disturbing issues. Several people would question the decision of the government of investing very, very large sums of money in the construction of the new AIMS institutions. This is a process that's gone on over the last 10 or 12 years. The first decision was to create 6 of these in states with relatively poor health indicators. But the present government has expanded this decision and is building several more. And as many of you will be familiar, there's been a dispute in the last couple of weeks about the location of the AIMS in the state of Jammu and Kashmir, with both Jammu and the Valley demanding the setting up of an AIMS institution. So somewhere in the public imagination, and possibly also in the Ministry of Health's thinking, the setting up of an AIMS at a cost of 10,000 crores is seen as a very, very important thing to be doing. Now, this is certainly debatable. Is this the way to go, or do we need to be spending this sort of money in strengthening and staffing government facilities at lower levels, thereby enabling much better access? So this is a whole set of issues. There's a fair amount of data is available, but I believe some research, some analysis needs to be done of what have been the improved health outcomes as a result of this 10 years investment through NRHM in the building up of facilities. State-wise data is available. It calls for some work. Is there data, is there a result that tells us that health outcomes have improved? Closely linked to this whole question of physical infrastructure is the question of human resources. Because part of the problem of all these new constructions built by government is that while hospitals are being built, we don't have the qualified health human resources to staff them. And here I'm not talking only about MBBS doctors, but the whole range, whether you go from super specialists all the way down to ANMs, there are areas of tremendous shortage. I mentioned the new AIMS constructions. The new AIMS are suffering terribly from a want of qualified teachers. You have, I was speaking to the director of AIMS Jodhpur yesterday. 3 years down the line, they are still struggling with basic teaching faculty. And this is true. What is true of an AIMS is also true in several states of primary health centers. In my own state of Uttarakhand, I don't have the data with me right now, but there are primary health centers that do not have a doctor. And this would be true of several other states, or at least in pockets in other states. Now, there is some serious work is needed, and maybe someone here is interested in this question of where are all India's doctors going? According to the Medical Council of India, we have about 45,000 MBBS seats that have been approved in public and private colleges in the country. There are something like 406 medical colleges in India now, more than half of which, about 60% of which are private. Between them, they are producing, we are told, about 45,000 MBBS doctors every year. There are approximately 22 or 23,000 postgraduate seats. Now, some serious work is needed of who are these doctors and where are they going? They are not coming into the government system. I'm not so sure about the capacity of the private system to absorb all these people. Let us also remember that though there are 406 medical colleges, many of them are complete rubbish. And this is another issue to do with the whole Medical Council of India story. So they may not actually be employable in any sense. So these questions need some looking into. Who are these doctors? Vyapam just tells us how this whole story starts. I mean, the kind of people who come into medical college, or how they come into medical college. So that gives us some leads as to where they are going. They are not coming into the government system. Where else are they going, and what are they doing? And so why is it that though the government at a policy level believes that yes, actually this figure of 45,000 MBBS has grown in the last 10 years or so. So government at a policy level believes that yes, we are doing a tremendous amount towards increasing the number of persons being trained in an MBBS program in the country. But it's not producing the desired result. So there are issues to be, and this is only about doctors. The whole question of nurses, nurse practitioners, dentists, allied health professionals, we do not have I'm not sure whether it's a good thing or a bad thing, but we don't have a council for allied health education in the country. So we see a mushrooming across the country of institutions or institutes that train laboratory technicians, X-ray technicians, ICU technicians, people like this. Now this is a totally unregulated area. And no robust health system can function unless you have properly trained, properly regulated persons at every level of training. A&M training colleges exist in every state in the country, but again, the experience of the states I know, they are frozen somewhere in time. There is an 18-month training which is given to a girl who has passed school, class 10 in many cases, maybe class 12 in some states. And that 18-month training is supposed to see her through the rest of her life as an A&M, functioning under somewhat difficult conditions. So the whole need for, not enough attention has been given at a policy level to the whole need for, turning A&M education upside down, for turning nursing education upside down. Given the Nursing Council of India, not much better than the Medical Council of India, but does not tend to get the same kind of critical attention that the MCI does. There are many things wrong with the Nursing Council and nursing curriculum, syllabus, very basic issues of this sort have not really been attended to. Now, the reason I mention this because the quality of the staff available at any health facility, public or private, is clearly determines access. If there is a facility with hopeless staff, nobody will go there. If there's a facility with no staff, there's no question of anybody going there. So somewhere we need a system where the growth in the construction of or the establishment of medical facilities is matched by the availability of properly trained and well qualified staff at all levels. The next big question, of course, and it came up in one of the slides that Professor Doyle showed us, is the whole question of financial resources. And something like 85% of all expenditure on healthcare in India is believed to be out of pocket. Now, this is linked to the huge discussion on universal healthcare. What does universal healthcare mean? Many people now today raise the issue that government really cannot afford universal healthcare. The present government seems to be talking about, if the draft health policy 2015 is any indication, the present government seems to be talking about a much greater private sector involvement. It talks, admittedly at a very general level, about health insurance and the drawing in of a large number of private providers who will be paid presumably by the insurance system. Much more, very specifically on the insurance question and health insurance as a means of financing healthcare, I think much more work is needed into the data we already have, whether this is data generated by the Rashtriya Swasthya Bima Yojana, RSBY, or whether it is data generated under Arogya Shri in Andhra Pradesh, or there is an equivalent scheme in Karnataka. Much more serious work is needed into what kinds of complaints were actually covered by these insurance payments, disease-wise, locality-wise, gender-wise. Because there is data available, though the Ministry of Labour is, now the Health Ministry is very, very reluctant to share this data with anyone, of who exactly has availed of treatment under RSBY, for what kinds of diseases, in what kinds of facilities, how many of the facilities that have paid out RSBY payments are private, how many are government. This kind of data is very important, an analysis of this data is important, if we are to try and make a go of an insurance scheme and to wholeheartedly embrace an health insurance program without any analysis of the data we already have seems a bit short-sighted. There is also the question of, if indeed universal healthcare is to be funded by insurance, who is going to pay these premiums? Does the government intend that government pays the premium on behalf of the population, and has anyone calculated what this costs as against a system where which government itself continues to be, as as is the case now, the primary provider, at least at the primary level. So this area is bristling with questions that have not been answered, of an area which calls for a closer look at the data which exists, and a much better understanding of what we mean by universal health care. Many people would agree that all persons are treated for all complaints up to the primary health care level, which takes care of about 70% of all health transactions, and with some sort of tapering off. So there will be some people who will be entitled to completely free care even at the tertiary level, as currently happens in the AIMS, for instance, or in JIPMER or in PGH Chandigarh, but that there would be some people who, based perhaps on an income criteria, would pay for that treatment at the tertiary level. Now, but these sorts of questions have not really been asked very, very clearly, and certainly answers have not been forthcoming. Then there's the whole area, I will not repeat many of the excellent points made by Professor Doyle. This interesting question came up about do women suffering from complaints other than those related to childbirths lack access to care in some way. This is a very fine point, and a particularly good example is mental illness, where we know, for instance, or the data says that 3% of India's population, which is about 40 million people, suffer from severe mental disorder. 10% of India's population, which is about 120 million, suffer from common mental disorder. These are very, very large figures now. And there are a very large number of women. We know that access to care in the case of mental illness is very poor at the best of times. And it is entirely possible that it is much more difficult for women to access care. There's a huge amount of work that is being done. I would particularly commend the work that happens in Chennai out of the Banyan, which is an outstanding organization that works with homeless women with mental illness. Now the point that was raised about cancer. So non-communicable disease in general is an area where the access to health care by women is possibly very limited. This needs work. I mean, I can make a general statement like this. This needs to be substantiated by specific area-based studies, some hospital data, PHC data. Is this true or is this not true? What exactly is happening to women with cancers, women with diabetes, where it's possible, again this is a hypothesis, that a man with cancer who is also earning a salary is the one who is going off to see the doctor, but a woman in a similar situation is not necessarily getting the same attention. But these are hypotheses which need to be tested. It is also, in the context of India, important to look at the impact of religion and caste on the whole question of access to health care. It is true, as all of us know, that large parts of village India, villages are still segregated caste-wise. The location of a health facility becomes a very, very, very important question as to which part of the village is the facility to be located, because that impacts on how easily or with what difficulty a person with an illness can access that facility. Then there's the old question that's been talked about for years and years and years about immunization, and there are people who oppose immunization on religious grounds. So much more, we need to know much more about these things and whether it's actually impacting. Something is clearly happening, because India's figure, our universal immunization achievement is still about 63%, which, all said and done, given the investment that has gone into it, given the fairly high profile that UI has always had, is still a very low figure. Bangladesh has come to 99, if not 100. So 63, clearly, if almost 40% of newborns are not being immunized, it's necessary to know what kind of factors are leading to this particular situation. And the last point I'd like to make about barriers to access is lack of knowledge. That there are still it's entirely possible that disease conditions arise in specific areas about which not enough is known. I was traveling once in Chhattisgarh, visiting the wonderful work done by Yogesh Jain and his colleagues at the Jan Swasthya Sahyog. And the kinds of diseases that prevail in that area, largely amongst the tribal population, which the government-driven system, as it were, just has no time for because it doesn't know anything about it. The average doctor posted into a public facility in that area has no idea of what specifically are the disease-related problems in the area in which he is posted. So there is a certain level of treatment, certain protocols available for well-known conditions, and very little known about specific conditions that may arise in certain situations where there are, but someone needs to know something about them, and this is this is an issue that needs to be worked. And I'm sorry, I said that was the last point I was going to make, but I do wish to just say very quickly something about, in the context of women and access to healthcare, the focus indeed has entirely been on maternal health and preventing maternal mortality, but the trend has always been to look upon just the act of delivery as just the focus. To what exactly is this woman's situation during her pregnancy, and what is going to be her situation when she goes home with a tiny underweight baby? What is she eating before the pregnancy, and what is she and her infant eating subsequently? The whole area of the relationship between nutrition and women's health is again one of the issues, Madam, which you mentioned about how women themselves are differentiated on this basis. So while the act of delivery may be something that is common to all women, the conditions they come from and the conditions they go back to are so vastly different that it impacts seriously on their health condition. So thank you. This is really all I wanted to say. As I said, my only effort was to try and identify issues, infrastructural, financial, gender-related, knowledge-related, human resource-related, each of which in their own way create barriers, and to each of which government in some manner has attempted a response, not necessarily the best response, but I think that's the purpose of discussions like this, to see where it is we can go and what it is we need to do to attack these issues.